You're listening to Charting the Future, a podcast for independent pediatricians by PCC. For more information about our software and services, please visit www.pcc.com or visit us on social media.
Welcome back, friends, to Charting the Future. This is Chip Hart from PCC, and we have a really fun guest today. His name is Dr. Herb Bravo. We've known each other for a while, which we'll get back to in a second. And I thought he would make an interesting guest because he's been up to a lot of fascinating work lately that I think is really important in the pediatric space. So, Herb, Dr. Bravo, welcome. How are you?
Great, Chip. How are you?
Well, I'm doing great. I just told him that I have contractors at our house, and I just got an alert that the smoke alarm is going off. So I might have to run out here in a minute, but I don't think so. I'm sure there is.
It may be God telling you that you need to move to a warmer climate.
Yeah. Oh, no. You know, we've had like probably about a foot of snow in the last week. Yeah, and it's awesome. That's why I live here. So, all right, Herb, here's my first question for you. You ready?
Yeah. Well, first of all, thanks for having me on the show. This is really going to be a lot of fun, and I love the people that you reach out to, all those independent practices across the country, and they're so dedicated to what they're doing. It's just a phenomenal community.
Well, we're going to get to what you are doing with your show because you guys are killing it, and I'm appreciative of all that work. So before we start patting each other on the back, let me ask you if you remember. Do you remember the first time we met?
My recollection is we met for the first time in Richmond, at a hotel in Richmond that the AAP chapter of Virginia had a management class. And
that is my memory as well. So we have the same memory. That's good.
And you had a booth. You had no one else but you. Back then it was just you. And we had very interesting conversations. And I think we exchanged, back then it was mostly emails.
Yep.
And then as always, you've been very generous with your time. And, we just kind of traded emails and back and forth. And I unfortunately never had the opportunity to be on PCC just because of the stuff I do. It's not something I have control over.
Yep.
But
that's okay. No,
that's another story. You don't want me to start talking about how much I hate the EHR I use.
Well, part of me does, but that's okay. That's not why we're here. I am sad for you that you don't have a good EHR because it just means you like your job less. But tell me, all right, so your memory aligns with mine, which is great. We did meet in Richmond. I mean, that was, Herb, how long ago was that? 15 years?
Maybe
more. Look it up.
Maybe more, Chip.
Yeah, a long time ago. But
they don't have the context there now.
That was when Ted Abernathy was running everything down.
Yes.
Yeah. Those are the days. Yes, I got called down to the Virginia chapter, asked me to give a talk, do a practice management talk, and I ended up doing an entire day by myself. And I learned a lesson. Don't ever do that.
No, you can't.
It's exhausting.
Yes. Yeah.
I forgot about that. So anyway, Dr. Bravo, tell us, give us a little bit of background history. Tell us about how you decided to become a pediatrician, what you're doing in practice now. Give us some color commentary.
Well, I think that the people that know me is I'm a very unusual pediatrician. And I became a pediatrician. I briefly describe it because I fell in love with pediatricians. And my love, not in a romantic sense, but my love was at the work that the Hospital Nacional de Niños does in San Jose, Costa Rica. And in particular, one pediatrician. Her name is Carla Olio, and she was, or is, a pediatric infectious disease specialist. She trained under George McCracken in Parkland, and she authored the article on using steroids for pneumococcal meningitis, which changed the way that everybody practiced before we had vaccinations against pneumococcal meningitis. That was a landmark study. And this woman must have been in her mid-30s when I was in my early 20s. And she was from Spain, And it's like, like you see in the movies, the beautiful dark hair, brown eyes, and then an intellect to boot. She would quote you articles verbatim and then turn around, open the file cabinet, pull it out of the file, write it in a notebook and said, Herb took this article, this date, to be returned this date. And I once said to her, but Dr. Audio, how do you know so much? And look at this whole file cabinet of articles. I am never going to grow up to be like you. And she said, you should see George McCracken's file cabinets. They take a whole room from the bottom of the floor to the top of the ceiling. And he knows each one of those articles. He's read them at least once. And I said, oh, I'm not good enough for this. She said, yeah, you are. You read, you're curious, and you're obsessive compulsive. I'm like, true. She said, and so George and I know these articles because half the people that write these articles we see several times a year. So you will be able to quote my articles without any trouble because you put a name to a phase and you've had many conversations with me. And so you will get there. It's just, you're not there yet.
Mm-hmm.
I'm like, wow, okay. So there's hope for me. And she said, definitely there's hope for you. You're going to be great. And then this is where I became a little bit of not such a nice person. She also taught me that you don't believe anybody. You don't believe the parents. You don't believe the radiology report. And you certainly don't believe anybody that says anything if they don't have a study to back it up. And that should always be your question. Dr. So-and-so says, rub, Bengay on the left toe when the kid has a cold. And your question should be, and where's the article that shows that's effective? Because talk is cheap. Well, when you ask for the data and you look at the data, they can see if you should do that for your patients or not. And you should never stop reading and you should never stop asking why. Show me the data.
Mm-hmm.
And
very ironic advice, not ironic, coincidental advice today.
I'm sorry, I shouldn't cuss on air, but it made me an asshole.
I'm not beeping that out, by the way.
Don't. I don't believe anything anybody tells me. Will you tell me that I should track, revenue per encounter? How do you measure that? What's a benchmark? Show me some data that makes a difference in the way that you manage your practice.
Yep.
And then when you prove it to me, I will do it religiously. But it does make you a little different than the American pediatrician in the sense that, I go in there and I'm like, yeah, the parents they don't lie because they want to lie to you. They lie because they're tired. They tell you a different story because they're embarrassed. They forgot something that was important. And if you don't dig into it, you can't diagnose the kid properly.
Mm-hmm.
And here's if you think that I have a little bit of a surgeon personality, oh my God, to be eviscerated by Dr. Audio, she did not learn management. She would dress you down in public with no mercy. And she asked me to go, I'll never forget the story. It's a great, great story because it makes me laugh now. But I was just a medical student. And she asked me to go do the initial write-up for our consult on the general ward for a kid who had fever of unknown origin. So I went down and I looked at the kid and he had a cast. And I asked all the questions and I looked at the labs and, he had these fevers and no good reason for these fevers. And it didn't seem to be an infectious disease problem. But because, she would not allow it any other way. If there was a smear in the lab, you had to go look at it. if there was an x-ray, you have to go look at it. And so he had a cast. So I assume he has to have an x-ray at the hospital because he broke a bone. I went down, had them pull the x-ray, took it to the pizza radiologist. We sat down and we looked at it, and the pizza radiologist says, "Oh, Herb, this kid's got a pathological fracture." I mean, how do you know? I said. He says, look at the borders of the bone. This is not, he just didn't fall. There's something more to this. There's some sort of cancer. I'm like, oh, okay, thanks. I wrote it all up, went up to her office, and she said, okay, tell me. I said, the kid's got a pathological fracture. This is not an ID thing. Oh my God. She got up from that chair and she said, let's go down to the ward. She walked into the ward. She said to the senior resident, which is like, see, I'm a medical student. This is a third-year pediatric resident at one of the best pediatric hospitals in Latin America. He said, get your team together where I'm going to teach you something. We went to the bedside. She examined the patient. She went back out and she said, what is the question you're asking of me as an infectious disease specialist? Because there's only 2 of us in the hospital. The kid's got fever of unknown origin. He said, oh, really? He said, the kid's got a pathological fracture that you never bothered to look at the damn x-ray. So you're wasting my time and you're delaying his diagnosis. Call the oncologist. And if you don't ever call me again unless you've seen the x-rays yourself, looked at the labs yourself, and you know what you're talking about. I don't need a medical student to teach a third-year resident how to do their job. And then we walked out of the ward. I said, for sure, I'm going to be killed in the parking lot. And I said, you can't do that. You just threw me under the bus. He said, grow a pair. Being a doctor isn't easy. They didn't do their job. Don't ever tolerate that. So that's why I became a pediatrician.
That is not the standard pathway to becoming a pediatrician.
No, but I love the science. I so admire those pediatricians in Costa Rica. They're so darn intelligent and dedicated. There wasn't anything they wouldn't do for their kids.
Yep.
And I'm like, I want to be like that when I grow up, but I never grew up. So here we are talking on the podcast.
What are you doing now?
Well, I'm really fascinated because I found my second Carla audio experience.
Okay.
And so I've always, and I don't have another word, and I apologize for the analogy I'm going to give, but this is how I talk. I've always hated what we used to call insulin-dependent diabetes mellitus, or diabetes of childhood, or juvenile diabetes. It's such a difficult disease to manage for the family. In some ways, is what lawyers tell you if the feds charge you with a capital crime. Your choices are to plead life without parole in a federal penitentiary, a high security one, or gamble and go to trial, and if you lose, they're going to put you in the electric chair. And I would say, well, I think I would take the penitentiary.
Right.
And the lawyers tell you, have you ever been in a federal penitentiary? Sometimes the electric chair is a better option. And that's what type 1 diabetes is like for families. You are put in timeout in a box. You are monitoring everything 60 minutes, 24 hours a day, 7 days a week. And until recently, there is no hope of a real cure. And lo and behold, we interviewed somebody that reminds me a lot of Dr. Odio, Dr. Simmons. She is incredibly bright, passionate, lives with T1D, and she's at the world's most renowned research center. It's called Barbara Davis Center in Denver. That was started by Barbara Davis, who was a billionaire, because her daughter lives with type 1.
Yep.
And I now understand that we can do so much to make this journey for all, not just kids, but adults, better and avoid complications. And so, and the science is evolving so quickly, and they are really evidence-based doctors. They've been studying this for the last 30 to 40 years. They follow people for something phenomenal, 15, 20 years to see what works, what doesn't work. And what we know now is this is not a metabolic disease. This does not have to be a diagnosis in crisis when you're in DKA in the ICU. This is an autoimmune disorder that starts very early in life and may progress very quickly or very slowly. And you can diagnose the asymptomatic patients before the crisis happens and your pancreas is blown out, and then now you do have a metabolic disease as early as 9 months of age. And you can prevent DKA, and you can slow the progression. And all those are phenomenal things that you can preserve beta cells. And I kept asking, why are you guys so fixated on beta cells preservation? The kid's on insulin. And the reason is, if you preserve some beta cells, whatever way you can do that, particularly don't go into DKA, because that's the worst thing you could do to your pancreas. But if you can prevent that, then you have enough residual insulin in your body that the outcomes, such as, the retinopathy of diabetes, which is the leading cause of acquired blindness in the U.S., can be prevented. And kidney disease can be prevented. And so your quality of life is much better, and you don't have something that the people, because not just the kids that live with type 1, just dread, which is the pathological lows. The alarm goes off, they have to run, they have to have glucagon around. But if you have a little bit of cells working, you don't experience so many pathological lows. And so just that makes their life so much better. And your insulin requirement is less. They're now talking this word. This word is phenomenal for me, Chet. This word's phenomenal. And I have to be careful because I get so excited about the future of this disease and the good that we can do for kids. I really feel like this is almost like, when we started using pneumococcal vaccines. But it is, I think, even better than when we started using inhaled steroids to prevent children from ending up in the hospital with asthma. And this is the same thing. This is at the cusp that we can change the story of this disease, and so many people will benefit. And the word that they're using now, I've heard it twice, is remission, which is, yep, you got stage 3 type 1. You have, your pancreas has been, hurt, but the amount of insulin these people need is minimal. Some of them now just have inhaled insulin that they do before large meals, so that they don't feel the hyperglycemia. And the rest of the time, they're just living their best life. And so to me, that's phenomenal. And I think the reason for this podcast that we wanted to get the word out first is, pediatricians, you need to learn about this disease. There's 3 stages. You can get autoantibodies done. And obviously, we will talk more about this at PMI when we see you all. But It's not hard. It's easy to do. And you have multiple pathways to do it. But one of the reasons that was holding people back is because there was no therapeutic intervention that we could do to delay the onset. So back in 23, they approved the first pharmaceutical as a biological that will, on the average, delay the onset of diabetes by 3 years. Imagine that. You have a 2-year-old and you give them the medication and they won't require insulin till they're 5. Or a teenager. They're 15. They'll be 18 when they require it, or maybe not. Some of the kids in the study are 7 years out and they don't require it. So that was great. But the problem was that it was only approved for children 8 years and older. And Dr. Simmons and a group of other investigators just completed, published, and reported an interim analysis of using the disease-modifying monoclonal antibody down to age 1. And there is absolutely no additional safety signals. So it's safe. And at their interim analysis of about a year, only 9% of the kids that they were watching progressed from stage 2, where they're dysglycemic, to stage 3, where they need insulin because they're hyperglycemic. So 90% of the kids are responding positively after 1 year, with no additional safety signals than the efficacy study. And so the FDA is now granted expedited review, and they're going to be giving us an answer by April 29th of whether this can be used down to age 1. This is really going to mean that you're going to have to do those autoantibodies when you test for anemia or lead, so that you can have these very brittle kids, which are the youngest, have an option of getting this treatment and having a better life. So all that to me is phenomenal, right? So, this is like, like science fiction. Like, I can't believe, I don't know what I'm doing in this space, but this is phenomenal. And that wasn't enough. The same monoclonal antibody is undergoing expedited review, and this worries me, by the FDA, and we should know shortly, to use it on stage 3 when you actually become hyperglycemic. Because the studies show that if you do 2 infusions, within 6 weeks of you requiring insulin, so you're hyperglycemic, you preserve beta cells. And although the other endpoints, which they weren't powered to look at, which was did they need less insulin and did their glycemic control improve, did not show statistical significance, the insulin requiring was trending to be lower for those that got the infusions. The problem is an implementation one, right? You have to know which patient's going to fall into that category because you have 6 weeks. If you don't have the autoantibodies before they need the insulin, then they're going to go into crisis. They're going to end up in the emergency room. And then the emergency room doctor is going to have to figure out whether or not they draw the autoantibodies. And I did emergency medicine, and I would be like, why? I need to correct this hyperglycemia and rehydrate them. The test usually takes 2 weeks to turn around. Then once you get the test back, you have to redo the test, send it hopefully to a research institution to confirm it. That takes another 2 weeks. And the insurance approval can take 4 weeks. And you want to give it within 6 weeks. So whether you want to or not, if you see patients in an exam room, whether it's in a hospital, in a private practice, and a private equity-owned private practice, you're going to have to make sure you advocate for your patients and make sure that they have the opportunity to get this medication. You're going to have to become familiar with the autoantibodies and track them down. So make sure they don't get lost. And I don't know how we're going to implement that, because many pediatricians, many endocrinologists, many pediatric endocrinologists still don't know that this is an autoimmune disease with a very, very well-defined pathway. You get the autoimmunity, well, we go back, you have some genetic predisposition, there's a trigger, you produce autoantibodies, but metabolically, you could not tell that patient apart from anybody else. Then it morphs into stage 2, where you're now having some glucose elevation, but not enough to be hyperglycemic. And then eventually, everybody who has the autoantibodies ends up hyperglycemic and needing insulin. How are we going to ramp that up? I don't have a clue, but it worries me.
One thing, Herb, I discovered as part of the experience I've had with this issue, I agree with you. I'm surprised how uneducated, I guess is the word I want to use. I'm trying to avoid it because I'm not trying to be insulting, or I'm not trying to denigrate anyone. But I've been surprised how uneducated many pediatricians are on the nature of type 1 diabetes. And just the simple, I am a million miles from being an expert, but I now see, like, oh, so because someone in your family has Crohn's disease, you should be screened. It's an autoimmune disease, as you are saying, and it has caught me off guard how many pediatricians aren't aware of that.
It's not just pediatricians; it's peds endos, adult endos. They totally, they think like they think like I used to think 2 years ago. When you need insulin, you got diabetes.
Yep.
Okay, that's when you know you got diabetes, and I don't manage insulin, so it's the endocrinologist problem. And the endocrinologist, has in their mind, well, it's a child. Children, particularly under 10 years of age, don't get type 2. So, if you're a child and you're hyperglycemic, and you present in DK, you got type 1. I just need to manage your insulin. I don't need to know anything else. And that's just, remember, it takes at least 11 years to create a pediatrician and 14 years to create a pediatric endocrinologist.
Yep. And oh my word, are there not enough pediatric endocrinologists?
There's not. There's only 1,200 in the country.
Not even close. Yeah.
Only 1,200 in the country. And many of them just do research, or their research interest is not diabetes. So they won't see patients living with diabetes. They may be bone doctors, or they like thyroid diseases. And their whole clinics are full of people with thyroid disease. And they never touch a patient with diabetes.
Yep.
But even the adult, right? I forgot the number, but I think it's over 50%, if not more, of counties in the U.S. do not have an endocrinologist. Adult.
It's, so we have this borderline epidemic. It's crazy.
Yeah. So we have homework to do. We need to learn, and we need to learn fast. So time's of the essence.
Well, the other thing I'll add, and this one element to what you just explained, one of the advantages or one of the goals of preserving those beta cells is that the next phase of the cures, of the stuff that will actually perhaps in our lifetimes see a cure for these things. It's going to start with people who still have endogenous cells.
Yes.
That's another reason. So for all the lifestyle things that you point out, It's totally worth it to save that pancreas, right? But it's important for future research and future results.
So every kid you screen is another data point that gets us closer to the cure. And the people that are really in the know are using the word remission. And it looks like, and there's a multitude of therapeutic interventions in the pipeline, including immunotherapy, where you teach your body to stop destroying the pancreas, just like you get allergy shots so that you don't sneeze when there's pollen.
Yep.
And, they're using verapamil, which is a cardiac drug, for preservation of beta cells. And there's a pipeline of other biologicals. And so, to me, when I hear them speak, and they're talking about, this medicine that we have now, it seems like it's going to be an induction agent to stop the process. But we may have to find a maintenance agent that we give people every so often to keep their pancreas going. And so the cure, I'm hesitant to use the cure because I don't give people false hope. But
right.
The cure may look like Crohn's disease with these biologicals. You still have Crohn's disease, but we're not taking your colon out when it perforates because you don't get to that point. Or HIV. Nobody really, although there's been one or two people that actually are cured from HIV, but the vast majority of people living with HIV are not cured. They're in remission. And they live absolutely full lives. They take their pill or their shot now. I think there's a shot you can do once a month now. And then they don't become immunosuppressed and they don't infect other people. And so they're thinking that people living with autoimmune diabetes will go into remission. And their pancreas will function, and they may need some sort of intervention. Nobody knows if it's going to be every 3 months, every month. They take a pill every day that allows the immune system not to attack the pancreas anymore, and they produce insulin. And I think that is within the realm of being achieved. And they're getting closer and closer to that stage of remission. And that would be such a godsend to put this monster out of business.
Yep. And I have great empathy for those families who have been managing their diabetes for decades, and the cure has always been around the corner.
Yeah.
But even though the cure isn't here yet, I mean, you know this. You look at it. The difference between being a type 1 diabetic in 2026 is so different from being a diabetic in 1996, in 1976. I can't imagine discovering your 1-year-old is a diabetic.
I mean, look at the story Dan tells, right? 3 kids. The youngest one was diagnosed at 2 in DKA.
Yeah.
And his wife kept 3 binders. That's color-coded. One for each knee, so they could keep track of the glucose and the amount of insulin they've given each one of the 3 boys. And like I said, it's every minute of your day, and it involves your parents, your siblings, your classmates, your school bus driver, the person that teaches you little league, the preacher on Sunday school, because you could become hypoglycemic at any moment, and they need to act, and they need to know. It is an unrelenting disease, very, very tiresome for people that live with it. So, but I think, that's a sad part of it, but the exciting part is we have something to do. We have something that changes the trajectory of the disease. If we just do our part as pediatricians, just like we give pneumococcal vaccines or HIV just get the screen and then have our colleagues and friends in endocrinology, push this to where we want to get these kids into remission and they can live a full life without insulin shots or pumps anymore. We just need to help them a little bit by finding the kids early and give them the opportunity of closing that gap, getting to the goal line.
Yep. Oh, okay. So, Herb, first of all, thank you for doing all that work, and I appreciate how much you've done to drive the attention to this topic.
Well, thank you.
All right. I have two questions though to take us out of here. First question: what is keeping you up at night? What worries you as a pediatrician?
What worries me as a pediatrician is that we're not ready for this discovery. And I have 35,000 colleagues to educate and persuade. And the only way to do this is, well, there's many, many ways, right? So showing up to PMI, and Polly's been a phenomenal partner along you and Dan Fighton. Mm-hmm. So showing up to PMI, just, keep preaching. But the other one, I think part of some of this change is going to come from wonderful partnerships, such as the one that you and Dan have. So for those of you who don't know, between PCC and OP, which are the premier pediatric EHRs in the country, they have about 20% of the kids in the U.S., give or take 14 million kids in their databases. And these are independent practices, and these people are smart and they're doers and they change the world. And so Dan and Chip have volunteered to work together, even though they're competitors, to try to devise strategies to push this information to their clients so that they can act, they can learn, and they can change the world with us. And I really, when I talk about that, there's tears in my eyes. This is what I meant that I fell in love with pediatricians.
Mm-hmm.
We do the work. And we do it with passion. And we change the world because kids are malleable. And we can live a better world when we exit. But it overwhelms me, the amount of education that needs to happen.
Well, I think we're actually, well, I mean, I just know I've been in this community for so long. I think the amount of education and knowledge about this topic, more has been done in that regard in the last 2 years than the previous 20.
So now we have something to do, right? We have a pharmaceutical intervention that is a disease-modifying intervention. Before, people are like, okay, so I tell a family they're got type 1 because they're 2 positive autoantibodies. 100% chance they're going to need insulin through their lifetime. Probably nothing to do, so just sit there and worry. We'll check your glucose every 3 months. Now we have something to do. So now it's more urgent than ever.
Mm-hmm. All right, so I've asked you what keeps you up at night. What's exciting to you? What are you looking forward to? What good news do you have?
I just told you a bunch of great news.
I know, but
look how much. Well, I mean, really, like I'm very excited about, the collaboration between the two PTHRs. That's to me phenomenal because I think it's going to help change the world. That I'm very excited about. I think that I'm very excited about the future of type 1. I think we're going to find remission. And despite of all the other turbulence, I really do think that things are going to stabilize, at some point, and we're going to come back to some center where everybody's going to be a little more comfortable. And the EHRs are going to change to where they're actually tools that help you take care of patients.
Mm-hmm.
I don't know what they're going to look like. And I say this often, for those of you who are old enough and were in America Online and used their browser, Netscape, everybody thought that Netscape was going to be the face of the internet. No one envisioned smartphones back then. So we don't really know what the EHR will end up looking like. I know it's going to go tremendous transformation, but I think that's my analogy. The EHRs were built on the Netscape platform, and with the AI and large language models and the recent gains in computing power, I am very optimistic that they're going to change to be more like your smartphone, more like an iPhone, where you want to use it and it's easy to use, and it actually adds to your happiness in life if you're not in social media all day like I am. But it's like just putting in where you're going on the car, or that I'm flying tomorrow to Austin, and I already downloaded my boarding pass. I don't have to.
You're looking forward to EHRs that are actually helpful.
That are helpful, yeah. That'll be easy to use like a smartphone, and that will bring value to me as a clinician. And I think that's going to happen.
I hope so. I mean, believe it or not, I say this as an EHR vendor, we're not the ones in charge of that.
I understand. Yeah.
As long as EHRs are really exist for the insurance companies and the feds and, the lawyers, because that's what they're there for, we've got a problem.
Yep.
So,
yep.
Well, that's a whole nother discussion. Maybe I'll hop on with you and George.
Yeah, that would be wonderful. Anytime. You're welcome anytime to come talk about that.
Yep. All right. Well, Herb, I'm going to see you in a couple weeks. And,
yeah, looking forward to New Orleans.
Yeah, it'll be an interesting time.
Yeah, and don't forget, if you can't make it to New Orleans, you're lost. But you could always. I think Polio offers have virtual on demand, right?
I believe he does. I don't know what the status is of it. I don't know if he's sold out or not of that, because there are definitely some limits on it. But yeah, he'll record it, and there's going to be some really, like there is every year, there's some really great stuff there. So
yeah. So looking forward to seeing you then.
All right. Well, thanks, Herb. I appreciate it. And
my pleasure. It's always great to be with you.
Thank you for listening. More information can be found in our show notes. Production and editing by Chip Hart, Ali Squires, and Chris Forleo. Music by Challenger C. I'm Mark Herney.